Okay, good morning, everybody. Very welcome at our Child Health Priorities Conference. Sorry, there you go. My name is Ute Feucht, and I'm a pediatrician from Pretoria. I'm just wanting to confirm with my team whether the slides are visible.
Yes, we can see them.
Okay, great stuff, because I have the problem that I can't see the slides at the moment. So that is a bit of an issue here. I don't know what went wrong with the setting now. But anyway, my role is firstly to welcome all of you. Thank you very much for joining us. We're going to have 2 days of very exciting deliberations on child health issues in our country. And we are very happy to welcome all of you. The Child Health Priorities Conference is, as you know, a yearly conference. And this year we opted to have another virtual conference, and we will have a discussion around this afterwards at our annual meeting tomorrow, which we will then discuss about next year's conference, whether people feel that we should be meeting in person again, or whether the virtual format actually works better for people. But for now, this is where we are with our virtual conference. So it's 2 days, as you know, from the program. It's today and tomorrow. It is from 10 to 12 and then from 2 to 4. And we're welcoming everybody. We have 186 delegates who are registered, and we are very happy to engage with all of you. And please use the Q&A and let us discuss. We will have question and answer sessions after each of the sessions, and let us make the most of this in terms of us engaging with each other. So thank you for our two first speakers. So we are going to start off with Sufang Guo from who's the Chief of Health and Nutrition at UNICEF here in South Africa. So she will be giving us a perspective from UNICEF's side in terms of excellence in child healthcare provision, because as you would have seen, that is our topic. And then we're very happy that Ameena Goga will be joining us who's joined us from Geneva to actually give us the keynote address to start off with. So let me stop sharing so that Sufang can share her slides so that we can start off with the first presentation. Thank you, Sufang.
Hi, morning, colleagues. Can you see my screen? Hello, morning, colleagues.
Yeah, we can see that, but it's not in presenter mode.
Okay.
Just go back to the display settings and duplicate. That's it.
Okay. Okay. Good morning, colleagues. Good morning, Professor Ute. Good morning, doctors, nurses, and everyone. Thank you for inviting UNICEF to join the meetings. The title of my presentation is Excellent in Newborn Health. I try to narrow my presentations in newborn health. So South Africa under-5 mortality rate reduction is mostly due to the post-neonatal mortality reduction. So the neonatal mortality rate hasn't changed for decades. If we compare with the other upper middle income country, our mortality rate is doubled or tripled other upper middle income countries. So that's why I want to zoom in the neonatal mortality rate reductions, which in fact we should focus on the small and the sick newborn care. So two areas I'm going to touch base. The first one is historical and the current neonatal mortality reduction by phases of care. And the second is child survival thrive and transform through improved quality of care. Historical and the current mortality reductions through care for small and sick newborns has been classified into three phases. Phase one, broader public health approaches when the neonatal mortality rate is higher than 30 per thousand live births. Phase two is when neonatal mortality rate is between 15 to 30 per thousand live births. And then the safe delivery and the management of obstetric complications and essential newborn care. Okay, so the phase three is when neonatal mortality rate is lower than 15 per thousand live births, which we focus on the special and the intensive newborn care. South Africa is the national level neonatal mortality rate is 11, which is you see on the phase three, but there are provinces neonatal mortality rate is in this in the right area. So for the province that neonatal mortality rate is over than 15 per thousand live births, so the interventions package for newborns should focus on the safe delivery, management of obstetric complications, essential newborn care. And for the healthcare providers, skilled nurse, midwife, nurse clinical officers, lactation specialists, and the pediatrician, of course, and family-centered care approach, and parent newborn as a unit of care is recommended. And for most of the provinces is on the phase three, so the special intensive newborn care, respiratory support, more advanced feeding support, therapeutic hypothermia, follow-up care for neurodevelopmental growth. So that's the intervention package, and we need a specialized healthcare providers, neonatologists, and I would really like to focus on the neonatal nurse, which we really need to push, and other support staff, multidisciplinary team. So in 2019, UNICEF WHO has published this transforming care for small and sick newborns. So in these publications, there are three key messages. To ensure newborns survive, small and sick newborns should receive cost-effective, evidence-based solutions to prevent newborn deaths and disability. To ensure small and sick newborns thrive, that small and sick newborns should receive quality care that require an integrated, resilient health system, multidisciplinary team, and innovations. The third element is transform to reduce barrier and discriminations to ensure all newborns and their families received quality care. So to survive all these cost-effective interventions as mentioned previously, but here I really want to emphasize for the small and the sick newborns really need intermittent and continuous kangaroo mother care. And you all know how important this is. And for small and sick newborns who admitted into intensive care unit or or high care unit, have you tried the intermediate kangaroo mother care? When you perform kangaroo mother care, can we do continuous KMCs to ensure the KMCs or the kangaroo father care, kangaroo grandmother care, etc.? Is it possible to make sure the infrastructure is suitable and the rules for family is suitable, etc.? So we all know that disabilities after preterm birth, such as neurodevelopmental impairment or vision impairment, retinopathy of prematurity is directly related to the quality of inpatient care and is one of the visual impairment which is preventable by safe use of oxygen. Investment in cognitive potentials starts with a proper care to premature babies. Therefore, small and sick newborns need developmental supportive care. So to ensure children not only survive but also thrive, it's time to introduce the developmentally supportive care, which include 5 elements, covers both care provider and the parent families. As listed here, protecting skin, optimizing nutrition, safeguarding sleep, minimizing stress and pain, and positioning and interacting. So I saw the South African neonatal guidelines, which almost covered all these elements, such as how to maintain the humidity, how to that handle with the light, and also the noise. And the ESOs just how to implement those guidelines and how to make sure the infrastructure is suitable for performing the kangaroo mother care, kangaroo father care, and also the nurse has the right skills, not only doing by themselves, but also can teach families and the parents. So who provide care? Multidisciplinary team, right? Which need a nutritionist, speech therapy, etc. The evidence shows that small and sick newborns survive in facilities closely linked to number of qualified nurses working per shift. Staff shortage, that's very common, but how to ensure a quality people-centered, family-centered care. So how to strategically address the staff shortage, especially strategically limiting hospital rotations or task shifting, task sharing, those are very important strategies to cope with the small number of specialized staff, but really need to be formalized to prevent confusions, and also the training, pre-service and in-service trainings, mentorings, and the cooperation between the university. You have many good universities, well-known universities, how these universities can work with the facilities so that improve quality of newborn care. So it's not only the nurse, but also parents and the families can play the role. And also nurses plays a crucial role to teach mothers, families how to provide care. But parental involvement should not exceed parents' comfort levels and should not replace qualified staff. And how about discharge, after discharge or beyond? This is also crucial things that we really need to think about. And before discharge, how there's healthcare providers to talk to the families and also to schedule the parental care, and also what kind of preferred learning styles and all these things, and for the follow-up who should follow up the families with the premature babies, and what's the important things need to follow. All these things need to be considered. Regarding the screening and monitoring, a newborn screening program that's very important, and also screening and monitoring for growth and early childhood development is important across developmental stage, even into the school age in some cases. And the assessment approach, you have the Road to Health booklet and how to use that screenings, and also provide early interventions. That's really the other things that we need to consider. And it's not only the screening and continuing providing support to premature babies, but also mothers. The mental health of the mothers is very important, giving the premature parents, especially mothers, has a high risk to experience the distress and also anxiety, etc. So the last component is transform. Reducing barrier discrimination is crucial to reach all newborns and families, especially in South Africa. Teenage mom, there's a big amount among the vulnerable group. So how we can make sure those teenage moms can access and their children can access financially, physically, and culturally. So conclusion, scale up interventions would provide returns on investment, preventing maternal and newborn deaths, stillbirths, and disabilities. Focus on the first 1,000 days. How is very important, not only in the clinical settings, in the hospitals, but also in the follow-up in the primary health care, and supporting the newborn and the families through the early detecting of disabilities and developmental delays and routine follow-up. Prioritize developmental supportive care to improve outcomes for newborns. With this right care, small and sick newborns can survive and thrive. Thank you so much.
Thank you very much, Sufang. You got us off to a fantastic start, so thank you for that. And so we are going to continue with Ameena Goga, who's joining us from Geneva. So Ameena is well known amongst South African child health audience, because clearly she is South African. She's just hiding in Geneva at the moment. But Ameena used to work as a researcher for many years at the SAMRC and is now working at the WHO in Geneva. And we gave her quite a difficult topic, I think. So child survive, thrive, and transform, meeting the needs of sick and well children through quality pediatric care. So thank you, Ameena, for giving us this keynote address. And and we will take discussions and questions then after for both Sufang and you after your presentation. Thank you. Over to you, Ameena.
Thank you, Ute. Thank you for the introduction, and it's really a pleasure to be here at the Child Health Priorities Conference. It's such an important meeting of a critical group of people. So thank you very much. I just want to check that the slides are showing properly in proper mode.
Looking good.
Okay. So what I thought I'd do in this 30 minutes or so, and hopefully I won't take 30 minutes, is to just quickly go through a vision for quality. So what is the vision? How do we or could we deliver and monitor quality care? Then a very quick focus on well child visits, and then just a little bit of information on research agendas. So off to a start, the vision for quality. And I think I couldn't leave this slide out. Initially I did, but I thought I have to contextualize this. So We all know that we're really struggling a little bit to bring down mortality for neonates and children, that we are a bit far away from reaching goals. And so I thought I'd bring the slide up, looking at the proportional mortality for neonates from different causes. And I think what most of us know is that prematurity and intrapartum related events remain the leading cause of death across different levels of neonatal mortality rate. So what this slide shows is that there's across different levels of neonatal mortality rates, from very high on your left-hand side to very low on your right-hand side. This is the proportion of mortality accounted for by specific conditions. And the one in the orangish kind of color, I hope it shows as orange on your side, it's like a salmon pinkish orange, starting with 29% on the extreme left and 36% on the extreme right. That's really preterm birth complications. So prematurity and intrapartum events or related events remain leading causes of death. And then what you see in purple, light purple or lilac, are congenital anomalies. And you'll see that as the neonatal mortality changes in countries that have very low neonatal mortality, let's say the US or UK or some of the Scandinavian countries, congenital anomalies account for a larger proportion of deaths. So what about children, is under 5? And here, this is what it looks like. The graph is exactly the same. So on the left-hand side are countries with very high levels of mortality, so more than 55 per 1,000 live births. On the extreme right-hand side, that represents the causes of mortality in countries that have very low child mortality. And here what you still see, that salmon color is still, salmon orangish color is still pretty much there. So that's preterm birth complications. So prematurity still remains the leading cause of death across various levels of under 5 mortality rate. That pink, that purple lilac color is congenital anomalies. And you'll see that as you go to lower child mortality rates, congenital anomalies increase to about 30% in countries that have very low levels of child mortality. What about lower respiratory tract infection and diarrhea? So those are represented on the slide by the brown bars, which is diarrhea, and the green bars, which is lower respiratory tract infection. So you see that they're still there, and they're higher in countries that have higher mortality rates. So I think that just contextualizes what we're doing, or what we're trying to bring down. And I want to emphasize, we're not just trying to bring down the mortality rate, but as described in many documents, we're trying to bring down the mortality rates and ensure that children thrive and survive and grow up into healthy adults. And I'll come to that just now. So there are several documents that exist, provide global frameworks that redefine child and adolescent health and well-being. Firstly, I want to just highlight the Sustainable Development Goals. I'm not going to go through them, but I think everybody's aware of them. Then there's the Global Strategy for Women's, Children's, and Adolescent Health, the Survive, Thrive, and Transform Agenda, which I think most people know about. It's the pictures on the right-hand side, and it's a strategy that goes from 2016 to about 2030. So we're still within that time period to achieve the strategy. And there are several plans that go with this strategy, addressing several pieces. For example, the Every Newborn Action Plan or the Child Survival Action Plan. I won't go through them, but those are the documents that you can easily find on the internet. Then the Global Framework on Universal Health Coverage with quality. There's frameworks for primary health care, and there's lots of discussion and documents around integrated people-centered health services. So that's just some of the frameworks. This just tells you a little bit more about the global strategy for women, children, newborn children, and adolescents' health, just commonly called the global strategy. It focuses on 3 things. So you'll hear over and over again people talk about survive, so end preventable deaths. 2, let everybody thrive, or let children thrive. So let us ensure health and well-being for all children. And let's transform, let's expand in enabling environments. So what about quality? Because what we really want to talk about here is quality. And there have been many more discussions recently about quality. And in building the evidence for quality, there are 4 global reports. The one is a joint WHO, World Bank, OECD report called Delivering Quality Health Services. You'll see the picture there and the reference at the bottom. I can share these slides later. The second one was a Lancet Global Health Commission on High Quality Health Systems in the SDG era. Reference is also here. Then there's a National Academy of Science, Engineering, and Medicine in the USA that focused on crossing the global quality chasm. And then there's a recent Lancet series on optimizing child and adolescent health and development. And these all contribute to building the evidence for quality. But the question is, what is quality? And what is high quality care? And there are various definitions. So in the WHO OECD report, it said that quality of care is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So you want to increase the likelihood of desired outcomes, and it must be consistent with current professional knowledge. Then the High Quality Health Systems report says a high quality health system is one that optimizes healthcare in a given context by consistently delivering care that improves or maintains health outcomes, by being valued and trusted by all people, so it brings in people, and by responding to changing population needs. And then the NASEM report says all people and communities receive the quality care services they need and are protected from health threats without suffering financial hardship. So they bring in some of the financial issues. So I guess there are various ways in which we can define quality. It depends on your framework, where you're coming from. But ultimately, we're all trying to do the same thing. No matter how we define it, we're all trying to reduce morbidity and mortality and ensure healthy lives, not just for children, but as they grow up into adolescents and adults and as we all age as well. So the question is, how many or what proportion of deaths are due to poor quality versus non-utilization? And many times we kind of assume that most of the deaths are due to people not accessing healthcare. So they're not coming for healthcare. But what this paper says is that poor quality accounts for a very large proportion of deaths. And on this graph, you see poor quality is in blue. Non-utilization is in that pinkish color. And you'll see that for many of the conditions, cardiovascular diseases, neonatal deaths, maybe a little bit of road injuries, the blue bar is actually bigger or longer than the pink bar. And so deaths due to poor quality is becoming a real issue. Maybe it was an issue before, but we're becoming more aware of it. So annually, between 5.7 to 8.4 million deaths occur from poor quality care. So that's huge. And that's something that we can do something about, because we all work in health systems, and improving quality is something that each of us can individually do in our daily working lives. And the next question is, so where does preventable mortality occur due to poor quality care? And on this diagram, the darker the blue, the more deaths there are. So you will see Central Africa, Southeast Asia account for the highest number of deaths. This is per 100,000 people due to poor quality. You see where we stand as South Africa, the kind of not the darkest blue, but not the lightest blue either. We're the second darkest, I would say, not the darkest, but just below that one. So that's where we stand. And so a lot to do to improve quality of care. You'll see some countries are spared, and you can see which countries those are, which regions in the world those are. So I think the agenda's there. Our individual contribution matters. And I think that's really important, because a lot of time we wait for a policy, we wait for a guideline, we wait for a manager to say something, but ultimately our individual contributions also count within the limitations of the work. And I understand sometimes there's no equipment and supplies, But to whatever extent we can all make a contribution, that's our responsibilities too. So what are the reasons behind poor quality? So poor adherence of medical personnel to evidence-based treatment. So the treatment's out there, but we're a bit, haphazard about it, don't adhere to it. Lack of essential medicines, commodities, that's an important one that sometimes many of us as individuals can't do much about. That's why an organization like this is so important to advocate and lobby to make sure that essential medicines and commodities are there when they need them, for children who need them at the right time that they need them. Then patients experience disrespectful care, short consultations, poor communication, long waiting times. It's a hard one. Services are busy, people work really hard. It's frustrating. And so this one, yes, each of us does have control over how we behave individually, but sometimes it's hard when you've worked a whole night and you've been busy. Here we need to learn, or maybe we need to tap into various strategies that exist, maybe pausing before you see the next patient, catching your breath before seeing the next patient so that you see them fresh, as though you're starting from fresh, seeing them for the first time. That can help to improve patient experience of care, because it's a really important one. The other thing is that worldwide, 1 in 4 healthcare facilities have no water. 1 in 3 have no access to hand hygiene. 1 in 10 has no sanitation, and 1 in 3 does not segregate waste safety. So these are important issues, infrastructural issues that kind of relate to multi-sectoral interventions. They relate to governance interventions and architectural and bigger interventions. Again, an organization like this with key stakeholders can try and shift some of this, but it needs a larger level commitment, political will, as well as commitment within a country or within a district. So what is the vision of WHO? WHO says that efforts to achieve universal health coverage are aimed to provide all women, newborns, children, and adolescents access to quality health services, and that every woman, newborn, child, and adolescent receives quality health services throughout the continuum of their life course and care. And this life course approach is really important, for all of us. It's high quality care across the continuum of care, so at all levels of health services and across the life course. So when we speak about the life course, we're really talking about starting from newborns to childhood, to adolescence and youth, to adulthood, to older adults. And this diagram kind of shows the pathway of 2 people, person A and person B, person A in green, person B in blue. Person A born in a slightly different circumstance, person B born in a disadvantaged circumstance, a low birth weight baby. And you see the difference in their ultimate health and well-being just because of where they are, what they have access to. And, the aim is really to ensure high quality care for everybody. And ultimately, the idealistic goal is to reduce that gap. But I think it's something we've been struggling with for a really long time. So the question is, how do we deliver quality? How do we monitor quality? So there is an increasing focus on quality of care in maternal and newborn and child health at national level. And this is usually nested within the overall healthcare system. The suggestion is to introduce quality of care standards for all levels of care, but also to prioritize areas based on a local need, a local measurement. Maybe there's a particular issue with infection. So to prioritize areas to drive quality improvement in that area. The focus is not only on the provision of care, so that's provision from us as health workers or the health system, but also on how mothers, families, newborns experience that care. So it's a twofold focus. It's important to define indicators to measure performance, to inform quality improvement. Quality improvement has been there for a while. It's important to build capacity in quality improvement. And recently there's been some interesting papers published by someone at the SAMRC about quality improvement teams, what works, what doesn't work. It's worth having a read. And then to leverage ongoing efforts to improve quality of care in other program areas like malaria, TB, and HIV. So there is a handbook for national quality policy and strategy that focuses on defining national health priorities. What is the local definition of quality? And, you know, you can do this even at a local level. We don't have to wait for a national to make a move. Sometimes a group of people at a local level committed to a particular cause can get together and try and see what they can do in this respect in their circle of influence. So stakeholder mapping and engagement, situational analysis, looking at the governance and organizational structure, looking at methods and interventions to improve quality, looking at health management and also information systems because they can help us to measure where we start off with and whether any change has occurred, and then looking at quality indicators. This is a very busy slide. I just wanted to highlight a document on health systems interventions to improve quality. It looks at the system or the environment, improving clinical care. It also focuses on the patient, the family, community engagement and empowerment, and then how do we reduce harm? Because that's really important as health workers. We don't want to increase harm by providing poor quality care. There is a quality of care framework that has been adapted for pediatrics. So on the left-hand side, you'll see the general quality of care framework. On the right-hand side, you'll see the pediatric one. I've just highlighted the difference between the two. The pediatric one is really based on the overall one, but it also adds meaningful participation under effective communication. It adds child rights to it. It's got emotional and psychological support. It brings in the word empathy, so empathetic human resources. And it brings in the concept of child and adolescent-friendly physical resources to give child and family-centered outcomes. So just something to flag. So what about quality of care indicators? There's been a lot of discussion. Indicators have been developed for quality improvement. There's some global core indicators. There's some quality improvement indicators. And then there are subnational suggested performance indicators. What about the global quality pediatric of care indicators? So I've just highlighted some of them. The institutional child mortality rate is suggested. Treatment of the small and sick newborn with bacterial infection. So at outpatient level, KMC initiation, pneumonia treatment with the first choice or first line antibiotic. Anemia has been brought in because of the burden of anemia globally. There are others. I'm not going to read through all of them. HIV testing for mother and child in high HIV prevalent settings is suggested. TB evaluation for children, missed opportunities for vaccination. Then inappropriate use of antibiotics for cough and cold. This is a nice one to avoid misuse of antibiotics. Completion of medical documentation. You know, we have to see how we translate all this into practice, but these are the suggested list of core indicators. Patient knowledge and understanding of their condition and treatment plan, their satisfaction with their decision-making processes in care, awareness of child rights, counseling, access to play and educational material during hospitalization and clinical mentorship. You know, these are really nice lists, beautiful lists. I think the challenge is how do we put all this into practice? You know, what does it mean and how do we measure this? So I think that's something to be thought about. There's several resources to support the improvement of quality child health care at national and subnational levels. These are some of them, you know, the IMCI chart booklet, the pediatric ETAT, the hospital care for children handbook. So these are available to help improve quality of care. Similarly, these are, I think, the same, just put down in a different way. And then there's an implementation guide to improve quality of care for maternal, newborn, and child health. So, you know, as usual, there's a lot out there. You know, we're never short of documents. What we really need is to get down and see how we do this. So I'm moving on to well child visits. And this is just highlighting a document that's there called Improving the Health and Wellbeing of Children and Adolescents. And really what this document looks at is kind of complements IMCI by saying that there needs to be a concerted effort to maintain children in care, to provide well child visits. The proposal is to provide a minimum of 17 scheduled visits from 0 to 19 years. And during those visits to identify high-risk children, to provide support, and to refer children. The issue of risk differentiated care and risk stratification comes in here. And that's a piece of work that WHO is currently engaged in. So if a child has one risk, what does it mean for their ongoing follow-up? Let's say the only risk they have is low birth weight. But if they have more than one risk, let's say they have low birth weight plus preterm birth, plus their mom was really sick at delivery, they were never breastfed or hardly breastfed, then does it elevate their risk? And do they need additional follow-up visits in the postnatal period? So that's under discussion. And then what is the sensitivity of specific weight measures? We've been looking at the weight for length Z score. What we found in some analyses recently is that the weight for age Z score is still very sensitive to pick up high-risk babies. And so the thinking is around putting together some kind of implementation science research to use a risk differentiated strategy and to test it in the field. And there's been a workshop this week in India to try and see how that proposal can be put together. So this is just showing where the visits happen, the 17 visits. The 17 excludes the preconception and the antenatal. But I want to emphasize preconception. It's an important period, and so is pregnancy. And in South Africa, there's a project called Healthy, run out of WITS at Baragwanath Hospital. And I think Ute's team is now also collaborating, where they're looking at preconception care and what is the influence of preconception care on child growth, development, obesity. They have an amazing biobank. It's an interesting study because WHO is part of the Secretariat and Coordinator. It's also being done in 3 other countries. So it's not only South Africa, but it's China, Canada, and India. And the data sets are all harmonized. The protocols are not identical, but the data sets are harmonized. And I think it's going to provide valuable information on the preconception piece and on some issues relating to preventing NCDs, the developmental origins of adult disease hypothesis. So a research agenda to improve quality of care. I just want to highlight a few things. And this is WHO-led research at the moment across maternal health. I'll highlight about 2 or 3 studies there across newborns and infants, and then across child health. So Amani is a study to identify stillbirths, maternal and newborn deaths, and to identify biomarkers for maternal, fetal, child growth and neurodevelopmental outcomes. It's a prospective study in 3 to 8 countries, 3 to 8 because at the moment there are only 3 ongoing sites. It has had a maternal and newborn mortality study, a maternal morbidity study, a gestational age study. So there have been several studies built into it, and now there's a COVID-19 infection prevalence study, and now stool microbiome is also being collected. So it's really to look at the maternal population and link with mother and baby. So I think there are publications, so look it up. Then there's antenatal corticosteroids implementation research, and this is really to develop an implementation model to achieve high coverage of antenatal steroids use, and to scale it up and evaluate its effect on neonatal mortality. So it's an implementation research effectiveness study with a step wedge trial design. I think there may be 1 or 2 publications. I'm not directly involved, but the sites are Bangladesh, Ethiopia, Nigeria, and Pakistan. Then there's the immediate KMC scale-up implementation project, which is to integrate immediate KMC into existing district health services to scale up KMC and increase coverage across districts. That's happening in Ethiopia, Nigeria, India, and Bangladesh, using a step wedge cluster randomized trial design. So the protocol is being finalized. Then there's the PSBI study, which is an RCT looking at children or newborns who are not extremely sick, they have only one high risk or one low mortality risk sign, can they be treated with oral treatment instead of inpatient treatment? So it's tried to improve the experience of care and to reduce resources on health systems. This one focuses on pneumonia treatment, so implementation research on pneumonia treatment. This one looks at management and outcomes of chest indrawing for pneumonia to understand the current management and outcome of chest indrawing at primary healthcare level, being done in 9 countries, Ethiopia, Nigeria, Uganda, Zambia, India, Nepal, Pakistan, and enrollment is complete. Then this is one that I'm involved in to look at management of moderate wasting. So it's looking at children with moderate malnutrition, randomizing them to 3 types of foods, ready-to-use supplementary food, locally available food, and microbiome-derived complementary food for 12 weeks. And then giving them a voucher after that for another 12 weeks to see whether it improves their recovery and how does it improve their recovery. So looking at body composition. And this one is a study in looking at children 0 to 6 months old who receive very intensive breastfeeding support, which is what every mother should receive. If any of them growth falter, they receive additional counseling and support. They get up-referred, illness is excluded. And only in those who really don't manage, if they're randomized to an intervention arm, they get given a nutritional supplement. And so it's to look at the outcome of wasting at 6 months. And I think that brings me to the end. So for thinking through is, how do we identify priorities and opportunities for scheduling visits and bundling opportunities or packages? What is the optimal programmatic approach to improve quality of care? How do we address health systems transformation? Quality of care of visits is important. So we're not only wanting to focus on number of visits, but how do we link with other things like health promoting schools? How do we link with the nurturing care framework? And I guess the other question always is, what individual contribution can each of us make? So thanks very much, Ute. I think I have not left too much time for discussion, but I'm happy to take discussion and questions.
Thank you very much. That is fantastic. And you actually feel close by and not very far away. So thank you for a very engaging talk. Yeah, so the floor is open for questions. I see there's one in the Q&A that I'll read to you now. I just wanted to find out from Dave and Tanya, will people from the audience be able to also pose questions in person, or will they have to type?
We can unmute if somebody wants to ask an oral question.
Okay, so they would have to put up their hands, or how are we going to do that?
Yeah, they can raise their hands and then we can.
Okay, great. So yeah, everybody would have heard that. So obviously it's nice to ask your question in person, but let's start off with Gabriel Nell's question to start off with. What incentives do you think could be used in getting health professionals to be more effective in quality of care policy implementation on the ground?
Yeah, thank you. That is a good question. I think there's so many reasons why people are not engaged and providing quality of care, and maybe we need to take a step backwards and think about it. Is it a capability issue? Is it a motivation issue? Is it an opportunity issue? So to try and take a step backwards and understand what is it that's resulting in poor quality of care, and how do we get people engaged? If it's a capability issue, like they just don't know what the evidence-based guidelines are, then a solution is training, which is an easy one. But often that's not the case. Often people come to work and there's so many other issues going on in their lives, and so their ability to focus on what's in front of them, or their ability to engage with that mother-baby pair or that situation at work is often distracted by other things going on. And in that case, the intervention is not training. It's not even a quality improvement intervention. It's softer things like relationship building and making people feel like they're part of the team. We're trying to do something important here. And within that relationship to take cognizance of, where that person is, maybe they've got a gender-based violence issue going on at home, or maybe something's wrong with their child, whatever it might be, and to try within that relationship to not only be there for work, so to improve the quality of care, but to be there in a sense for the person as well. So maybe it's a bit of an unconventional answer, but the thing is, we're living in a real world, where we have real people, real problems or challenges. People have real challenges. And I think if we just meet the challenges by saying, oh, let's do another framework, let's do another quality improvement intervention, let's do another set of trainings, we're definitely not going to get there, because here we're working with real people who have real issues. And I think the soft issues of relationship building, understanding where they're at, is it just a capability issue? Is it a motivation issue? If it's a motivation issue, what's behind this motivation? Is it that, this is just a job. I just come here to get my salary. I just need to put the food on the table at the end of the month. I don't want anything else to do with this. What is it, And I think oftentimes people are people and the heart is the heart. And, the heart jumps out when you start engaging with people. And I think we need to get to that level before we can actually shift quality of care. Because it's not just it's not just a logical algorithm. It's not. So I think that's what I would say.
Yeah, and I mean the other issue is, it's good childcare is built on a strong foundation that needs to be there every time for every baby. Yeah. So the point, and many of these things are not very sexy. They are, hand washing or breastfeeding support.
Yeah.
And try and do a hand washing teaching session with medical students or something like that. They think it's extremely boring and this, I think, yeah. So here's a question from Jenny Nash from the Eastern Cape. She says, thank you for the excellent and thought-provoking presentation. Is the undergrad program perhaps focusing too much on the biomedical aspect of healthcare and not equipping future health workers on how to be pragmatic in challenging circumstances, how to work in teams, and how to interact with communities? Yeah. So this comes from one of our rural doctors.
Yeah, I think so. You do need both. You do need the theory, you do need the knowledge, you do need the evidence-based care. So you do need the whatever tools is going to help at a primary care level, a district hospital, a tertiary hospital. You do need all of that. But that's not the only thing we need, and we need to implement those in a context. And I completely agree with Jenny. We need to start focusing on those kind of softer relationship quality aspects. Otherwise, it's really difficult to shift things. So yeah, it's a great point, Jenny. Thank you. I agree. Yeah.
Yeah, there's another comment here on burnout among health workers, which links to your point as well.
Yeah.
And then Sufang, I see you've answered the one question about in the chat here in the Q&A, but maybe so this talks to the healthy mother. So central to a healthy newborn is a healthy mother. We are seeing many issues regarding increased substance abuse, alcohol use, and gender-based violence. How do we tackle these at community level? Sufang, do you want to provide an answer for everybody?
Okay, thanks for the questions. So for the gender-based violence, substance abuse, all these questions, social issues, you see those social determinants that cannot be solved by the healthcare providers alone. So we really need to work with the other sectors. So having the whole government or whole society approach to solve the issues, communities, I think they know what's the solutions. We really need to facilitate to the communities to work together with the different for the different sectors, working together and also find the issues, find the bottlenecks, and find the solutions so that to solve the issues. Over.
There you go. Thank you very much. That is true. We wish we could solve all the problems at once, which we clearly can't. There's a question here, Ameena, about wondering if a question we are not asking is whether there are enough nurses, health providers on the ground.
Yeah, that's it's a very valid question. And I think in all likelihood, the answer will be no, especially in most, if not all, countries who are in low to middle income settings. So I think that's a reality. And can we do anything about that? Not, we individually. It's a very difficult thing because it relates to employment and budgets and posts and all of that. I think some advocacy, must be done. But at the same time, for those people who are there, the question is, what do we do to facilitate their surviving in their environment, right? And it relates to the question of burnout. And I think this issue of burnout is really salient because it happens in busy places where the demand or the need is so high, in busy hospitals, also in rural underserved areas where you have very few health workers. And the question is, what do we do about burnout? How do we address it? Are we giving people enough time to kind of go backstage? If you look at this analogy of an actor and a play, right? They're on the stage. You have to perform, right? But the actor has to go backstage to refresh the makeup, to refresh the clothes, to change the outfits, whatever it is. And here we are with health workers. They're on stage all the time, maybe carry some of the challenges home with them. So is there a way that we can make the environment such that we facilitate this going backstage concept? And what is this going backstage concept in a work situation? Where you kind of, is it counseling, which is not there? But what else is it? Are there little things that individuals can do, or skills that we can teach individuals for their own self-care, to take the opportunity to go backstage to avoid this feeling of burnout, or to reduce the number that go into burnout, or to reduce the frequency of burnout? So those little things, I think, are things we have to start looking at, because not only is it good for personal health, individual people, but it also, because for some of these issues that take a really long time to create posts or appoint people, we have to care for the people who are there. And so this concept of going backstage, and what are we doing? Is it pausing? Is it sitting? Is it walking? And connecting with the environment. What are those little things that we can do just to make it easier for the people that we work with and ourselves as well?
Yeah, thank you very much. I must say, obviously the question is, what is the enough staff? There is no ceiling there, so which obviously makes this discussion really difficult. We've clearly seen, COVID has not been kind on mental health of people, and we're clearly still seeing the effects. I must say, the one thing that irritates me personally is, from if either the Department of Health or university sends out like, okay, here's like this mental health awareness, or do this and that, and then I always just park those emails and announcements, because I think, oh gosh, I don't have time for this. So I think your question is extremely valid. Like, how do we do this in practice that actually helps people and not irritates them, because they're busy anyway and they're not getting to everything that they actually need to do.
Yeah, and one other seminar is not going to do anything, but maybe me talking to you about something, and maybe that will do something. Yeah. So I see.
So last question here from Jenny, and then we'll move on to the next session. So South Africa has poorer health outcomes compared to GDP and investment in health. What 2 things would you advise South African health workers to focus on to try and improve the quality of healthcare in different levels of care? Last question.
Two things. That's a tough one. Maybe maybe know the protocols. We can't get away from knowing what we should do. I think that is a starting point for everybody working in facilities. We have to know what's recommended. So make sure we know those, and we know those well, and we put them into practice as much as possible. And then maybe the second thing is maybe be aware of how we interact with then the people who come to receive that care, because that's important. The way they perceive us, the way we come across, are we busy? Do we have no time to listen? Do we have no time to talk? What is it? Because they've made the effort to come there. So maybe just, each one of us just seeing how we come across to make sure that the experience of care is slightly better, even if all the equipment is not there. But, somewhere there's appreciation of this person really saw me and understands my problem. And oftentimes it's said that people come back. There was something I was reading the other day. People come back even if they don't get perfect treatment, but they come back because you were nice to them or because they see something that they're getting out of that. So maybe that's the other thing, because then maybe we'll have a bit more. Actually, it was somebody doing an adherence talk. And they tried different things, the electronic poll box and, all those different things, incentives. But the thing that really worked was them, they said being kind. That was their word. The thing that worked was them being kind, because people came back.
Yeah, and obviously that works both ways as well. You also feel better as a health worker if you are actually kind and you connect on that human level. Yeah.
Sure.
Great, thank you very much. A big round of applause for our two opening speakers, Sufang and Ameena. Thank you very much for getting us going and really thought-provoking talks. Thank you.
Thank you.
So we are moving on to the second part of this first session. You see lots of claps there for the two ladies. Thank you very much. Okay, so this is where we are now. We had the 10 to 11 session, and we are now moving on to thinking a bit about risk stratification in routine healthcare. Is this practical? Is it feasible? What should we be doing? And we will be having a talk by Lesley Bamford, who is the pediatrician and the current acting chief director of maternal and child and women's health at National Department of Health. Then we'll have a talk on and then we're going to zoom into three specific risk groups. So these would be premature and low birth weight infants. Lino Sono, who's a neonatologist from the DCST in Mpumalanga, will be talking about that. Then we have a talk by Sanya Nell, who's a dietitian, also from Mpumalanga, thinking around children at risk of malnutrition, stunting, and severe acute malnutrition. And then we'll have Sadna Bolton, who will be talking to us about special needs children. How do we identify them, and how do we unlock the care pathways? Yeah, so just you would have heard Ameena talking about this. So this is sort of, if we have a foundation of solid routine healthcare for all children, how do we then, on top of that, think around additional care for at-risk children? So as I've already alluded to, we will be having talks on the prematures, on the special needs children and children at risk of malnutrition. There are obviously many other at-risk groups of children. One very obvious one in our setting are the HIV-exposed babies, for whom there's actually a whole care pathway. But there's also socially at-risk children, and then a big other group with congenital abnormalities, chronic diseases, rare diseases. So clearly this hour will only get us to start thinking around this. It's not going to cover all these topics. But just that you see where this fits in terms of us thinking around this. So unfortunately, Lesley Bamford is traveling. She is in Addis Ababa, but we have a recorded presentation from her. So I'm going to ask Dave to get us going on that, please.
To address this conference, even though I am far. So good morning, everyone. And thank you for this opportunity to address this conference, even though I am far away at the moment. And I am very sorry that I am not able to join you, and really wish you a very successful conference. So today I have been asked to speak briefly about the Road to Health booklet, and particularly the extra care pillar, which for people who know the Road to Health booklet, and I hope that's all of you, extra care is the 5th pillar of the Road to Health booklet. And what we're really trying to convey through that pillar is to convey to caregivers that your child may need special care or support, and knowing what to do and where to go will help both of you. So I think that's a very powerful message, but one of the things that we have really struggled with is how do we operationalize that? And so I think today's panel discussion is really a very timely one. So in this slide, which I'm aware is very small, is just to remind you what is in the Road to Health book with regards to extra care. And there are 4 pages, and it talks about some children who need extra care. Children with HIV, children with TB, children with serious injuries, children with disability. We also talk about the importance of supervision. And then we have a little checklist where we try and identify children who might need some extra care. Children who don't have birth certificates, children who have a mother whose mother has died or is ill, a young parent or caregiver, a child who is eligible to receive a child support grant but not receiving a child support grant, and the same for care dependency and foster grants. And then really a little bit of information around children who might be at high risk, and some information about registering the child's birth, and some information about support and care grants. So I guess if you look at this, what it's really trying to do is to point healthcare workers and caregivers into some of the support, or towards some of the support that is available, but really from other departments, really around social grants, etc. So I think this is helpful information, but it certainly doesn't provide a platform whereby we are able to identify at-risk children, and particularly provide them with a package of extra care. Where else have we tried to do this? We have also included this in IMCI, again, possibly without too much success, but again, trying to identify children who are at risk either because of illnesses in their family, TB, etc., or because of particularly difficult social circumstances, or because they are a low birth weight infants. So in thinking about this topic, I think we really need to think about what are the challenges. So I've presented what we've tried to do to date, which I think we recognize is inadequate, but how do we move forward, and what are the challenges in terms of having a system whereby we do identify children who are at higher risk, and we respond to those challenges. So from my perspective, what are some of the challenges or hurdles that we face in doing this? First of all, I think there is a lack of a really good evidence base as to which children are at risk and which interventions are effective. So of course, we know we can identify some of the groups of children who are at risk. I think we know those intuitively: preterm or small or sick newborns, children facing particularly difficult social or socioeconomic circumstances, children from families with HIV, children with disability. But I don't think we have a very good evidence base then in terms of which interventions are effective, feasible, affordable, and how do we package those together. So that's one challenge. The second challenge is that many of the interventions rely on partners or are context specific. So the advice that you can give to the mother of a child with disability who lives perhaps in the Cape Town metropolitan area is different to the advice that you would give to the same mother if she lives in Tambo district, because the resources that are available are often very different. And thirdly, we have no comprehensive, or to date, we haven't had a comprehensive preventive and promotive package for all mothers and children. And what I'm really going to argue in the next 5 minutes is that this third one is something that we're really trying to address, and that what we really need to do, and I hope this discussion will really, this panel discussion will really point us in the right direction, is we hopefully going forward will have a platform for providing, identifying children at high risk and providing the interventions. And now we need to really agree and argue and come up with the content of which children are at high risk and what are we going to do about it. So what I'm going to talk about in the next few minutes really then is just the mother and infant baby package, the roadmap and the package that we want to develop around that. And I think I can skip through most of the slides, but this speaks to the issue of having a single preventive and promotive package for all mothers, newborns, and children. Historically, we have treated mothers and babies separately, and we have many different programs and guidelines which frontline healthcare workers are expected to implement. And what we need to do is to have one single document or roadmap that identifies all the services that mothers and babies can expect to receive in our health facilities. Now, what have we done to date to address this problem? We did start this process in 2019, and we developed a roadmap, and we actually took that roadmap to all the provinces, and it was very well received. However, COVID then intervened, and this process lost momentum. What has happened in 2024 is that the roadmap is now being updated. It will be piloted in Tshwane district, and it has been accepted as the basis for the NHI package of preventive and promotive services. So what does the package look like? It says that there are different types of visits that different reasons why mothers and babies come to our facilities. We would ideally like women to present for a preconception visit. Pregnant women then come for a number of antenatal visits. We have delivery, where we have interventions for the mother and for the baby. We have the postnatal period, where we again want to provide services for the baby, but also for the mother in the immediate postnatal period, and then moving into childhood. And one of the principles of this package is that mothers and babies should actually be seen wherever possible as a pair. So the roadmap identifies exactly what services need to be provided. This is an example of the, actually it's for the post, we've got it a bit wrong here. We've got the postnatal visit for the baby at 10 weeks and the postnatal visit for the mother at 3 to 6 days. But obviously they need to be aligned so that a healthcare worker should be able to open a single document and know exactly what services need to be provided. And we look at a number of services or a number of steps in the consultation, building rapport, looking at issues related to development, routine care, growth and nutrition, health care, including HIV care, preventative care, extra care, and giving the next appointment. So what is the way forward? Why am I presenting this today? And hopefully I've explained that. But because I do believe that the mother-baby-infant pair really provides the framework whereby we cannot only include the services that should be provided to all mothers and infants, but can use this as kind of a scaffolding to also think about what additional services or interventions need to be provided to high-risk infants. I think having an electronic medical record will also assist that process, and the expectation is that this package of services would also form the basis of an electronic medical record. But for example, once you have an electronic medical record, it is possible that if you enter the baby's birth weight and the birth weight is 1.9 kilograms or even less, maybe 1.5 kilograms, that could then automatically pull up a more intensive record, which would then prompt the services, additional services that need to be provided. But as I've indicated, I think for me, the real challenge is that I don't think we've really outlined what those additional services are. And I hope, as I indicated, that this conversation can really be the start of that, and we can figure out how we incorporate the different or have one single standard definition of high risk. Obviously, that needs to have different components, but that we are able to identify children who are high risk and then move them and have a very clearly defined package as to which each of those children needs. So perhaps it isn't very clear, but that we think about a risk in a standardized way, so that our nutrition services think about risk and interventions in the same way that we think about interventions for children who are at high risk because they have been very low birth weight, or we've identified them, for example, as having developmental delays, or as coming from families who have high risk factors. So I'm going to stop there. I think the final step would be then to incorporate them into the roadmap. We do need to finalize the roadmap early in 2024. So there really is some urgency about addressing this issue and coming up with this package. Thank you very much. Let me stop there.
Okay, thank you to Lesley in her absence. And obviously she's referring to 2025 in terms of getting the roadmap completed. So, but I really think this this puts us really on a very good road to actually discuss this further. So I'm going to hand over to Lino Sono, who's the neonatologist, who's going to talk about prematures and low birth weight babies. Lino, you can share your presentation. Yeah, that is perfect. Thank you. Over to you.
Okay, so this is the title of my talk about premature low birth weight infants. What extra care should we provide, where and for how long? So this is a 10-minute presentation, so I tried to summarize as much as I could. There's no, I have no conflict of interest. The presentation outline will include the introduction, definitions, how to identify high-risk neonates, the WHO recommendations for the care of preterm and low birth weight infants, some studies that have been done, and conclusion. So in terms of the introduction, prematurity is the leading cause of death in neonates less than 28 days of life. About 13 million babies are born preterm, which makes about 10% of all births. More than 1 million preterm infants die each year. And worldwide, the low birth weight rate is 14.7% according to WHO in 2020. In South Africa, the low birth weight is 13% according to the DHIS. So those who survive, they risk a range of disabilities throughout their lives. The World Health Organization has launched recommendations in 2022 for the care of preterm and low birth weight infants. Some of the definitions, the preterm infant is a baby who's born below 37 weeks of gestational age. They've been classified again into late preterm, which is a baby who's born between 34 and 37 weeks. A very preterm is a baby who's born before 32 weeks, and extreme preterm below 28 weeks of gestational age. The low birth weight is an infant that has a birth weight of below 2.5 kg. Small for gestational age is a birth weight below the 10th centile for the age. Low birth weight infants needs extra care because they are either premature or growth restricted. So preterm infants and low birth weight have a higher mortality and morbidity than term infants. So when we identify the neonates at risk at a primary healthcare level, we've got the Integrated Management of Childhood Illness booklet that was launched in 2022. And for the district hospitals, we've got a newborn care chart that have been in use from 2014. But we know currently National is working on the new guidelines that will include all levels of care. So for the primary healthcare level in the IMCI chart booklet, there is a chapter that deals with newborns from birth up to 2 months of age. And this includes the infant that has just been delivered, or the infant who's coming for postnatal visit or coming for neonatal complications, who's presenting at the clinic. For the district hospitals or maternity obstetric units, we triage the baby into sick or small neonates. Those are the ones that need care in the neonatal unit, or those that need routine care with the mother. And there's also a specific chapter in the booklet that deals with preterm and low birth weight infants, but there's also high risk groups that have been mentioned in both the groups. So the reasons for admissions for preterm babies, they are still the same. Most are preterm babies that are below 1.8 to 2,000 grams, they require admissions. The reason are respiratory distress syndrome, apnea of prematurity, hypothermia, sepsis, hyperbilirubinemia, hypoglycemia, and feeding issues. So we need to address all of those issues for a preterm. So the WHO recommendations were launched on the 17th of November in 2022, and they were based on the PICO framework. There were 25 recommendations. The 11 were new and 14 were updated. These recommendations were divided into preventative and promotive care, divided into care for complications, and also family involvement and support. There were 11 strong recommendations, and those were the new ones that were immediate kangaroo mother care. Immediate kangaroo mother care, meaning that we start kangaroo mother care as soon as the baby is born, before even stabilization of that baby. Caffeine for apnea and extubation. So they've recommended that caffeine be given for the treatment and prevention of apnea, and also recommended caffeine for extubation of those neonates to prevent extubation failure. Also, there's issue of family involvement and home visit, which will be done by the community caregivers. The updated recommendations were any kangaroo mother care that can be given at any time when the baby is born, giving of the mother's own milk, and where the mother's own milk is not available, to consider giving donor milk, early initiation of feeding and exclusive breastfeeding for the first 6 months, iron supplementation, CPAP for respiratory distress syndrome. So this was their strong recommendation. And also still under preventative and promotive care, any KMC, it's any KMC that, routine KMC that is being given, and also should be given between 8 to 24 hours, but as many hours as possible. So immediate KMC I've explained, and also giving the mother's own milk for babies that are below 1.5 kg or less than 32 weeks of gestation, and that also applied to the giving of human donor milk. So for the care of complications, what I want to highlight in this slide is the giving of CPAP immediately at birth for babies that are less than 32 weeks of gestational age, whether they have respiratory or no respiratory distress. And also they highlighted the fact that they preferred giving of bubble CPAP instead of other pressure sources of ventilation. But when we looked at the Cochrane review, there was no difference in outcome, whether there was bubble CPAP or other kind of positive pressure CPAPs that were given. The use of methylxanthine for extubation for babies that are less than 34 weeks of gestational age, also, as I have already mentioned. So family involvement has been mentioned also in the talk, where the recommendation is that the family needs to be involved in the care of their preterm babies, and then this has been shown that it improves outcome. And then they also had a good practice statement about the parental leave and entitlement. So these are some of the studies. This was a study that was done in Johannesburg, published in 2013, that spoke about the survival of extremely birth weight infants. And then in these studies, they also spoke about the weight for gestational age that had impact on the neonatal outcome, and also the type of feeding. CPAP in the study didn't show any difference, but the study that was done in Tygerberg, they mentioned that giving surfactant and also CPAP increased the survival of the low birth weight to 62.9%. So the reason I'm mentioning about the very low birth weight and the extremely low birth weight is that these babies, usually we struggle to transfer them. And they usually have to stay in the district hospitals, and even those that are born at the tertiary levels, they don't usually get ventilation in high care. So another study that spoke on the short-term mortality and morbidity of very low birth weight infants, that was done at Gross-Deskiri. So in this study, they did show that the mortality was 19.8%. But the morbidity was 31.5%, meaning that many of these children, they do survive with less neurodevelopmental outcome. The other study as well, focusing on the neurodevelopmental outcome, they showed that 36.8% of these infants, they are at the risk of neurodevelopmental delay. So that also shows that these infants, most of them, when they survive, they can have a good neurodevelopmental outcome with follow-up. So also the study that spoke about the use of caffeine. So where they gave caffeine 20 milligram per kg for extubation in the intervention group, and those babies were shown that they had less respiratory failure. So the last study also where they showed about kangaroo mother care, giving immediate kangaroo mother care or giving kangaroo mother care a few hours after the baby has been stabilized, and they did show that in the intervention group, there were fewer deaths at 28 days of life, although in 72 hours, there were no differences. So the last study was on the issue of human donor milk, and this has been shown that many communities, they accept the human milk bank, human milk. So in conclusion, preterm and low birth weight infants have high mortality. The interventions provided at varying levels of care can improve the outcome. Early KMC, early feeding with mother's milk, caffeine for extubation, and family involvement should be included in the package of care. And the majority of preterm or low birth weight infants have got good neurodevelopmental outcome. And we need commitment by political heads to ensure availability of resources, especially at the lower levels of care. Thank you very much.
Thank you very much. That was a fantastic presentation. And yeah, I mean, obviously low birth weights and prematures are, you know, we have a high burden of them in our system, and we really do need to think about both the immediate care and the follow-up care and the outcomes. And the fact that these babies are obviously not only born in tertiary big hospitals. So thank you, Lino. We're gonna move on to Sanya Nell to talk to us about nutritional aspects of at-risk children. You can already start posting questions to the presenters in in the Q&A, and then we'll have a discussion at the end. Thank you. Over to you, Sanya. Your slides are visible and all good.
Okay, perfect. I was just wondering whether you're seeing my slides on my presenter page. Okay, so I'm going to talk to you all about children at risk of malnutrition and how do we avoid this from turning into a disaster, which it unfortunately so often does. Now my slides don't want to move. There we go. Okay, so let's just start by setting the scene. Now, malnutrition means any kind of nutrition that doesn't meet the requirements of the individual. So malnutrition as a term includes overnutrition and undernutrition. But for this talk, we're going to take it to mean undernutrition because that's what we want to talk about. So for today, if I say malnutrition, I mean undernutrition. And the first kind of malnutrition that we'll be looking at is wasting. Now, wasting, we all know, is a low weight for height. Most often, this occurs when there's weight loss due to either illness or food deprivation, but it can also be part of a chronic malnutrition picture. Children that are wasted have a higher risk of short-term morbidity and mortality, and as we all know, severe wasting, when the weight height Z drops below -3, is classified as severe acute malnutrition, or SAM, and that's got a very high mortality rate, or very high risk of mortality. If we do our jobs well, the mortality rate hopefully shouldn't be too high. Okay, so the other side of the coin is stunting. Stunting is the low height for age, and that is caused mostly by poor growth. So you don't gain height and then lose it, obviously. Usually it will be a deficiency of protein and or micronutrients. So the child might be getting enough calories from other sources to maintain their weight, but because of the protein and micronutrient deficiencies, their length does not grow as it should, and they end up being too short for their age. And this implies that linear growth faltering can actually occur long before the child is stunted. So if a child was born with a length of -1 Z-score and over time, or +1, and over time that drops to -1, that child is experiencing stunting, even though their length for age is still normal. Stunting is very challenging to treat. It's very difficult to recover, especially once you've passed the first 1,000 days. And the risk here is long-term for neurodevelopment and morbidity, all kinds of acute and chronic illnesses. Now, these two things don't exist as separate conditions. Longitudinal research has shown that wasting, even when there's recovery, is often followed by a period of slow length growth. So wasting often contributes to stunting. And then conversely, once a child is stunted, they have less reserves. They are less resilient against an acute nutritional insult. And these two things can coexist. And that is actually a very bad condition, because a child that is moderately wasted but also stunted has a 2.5 times increased risk of mortality compared to a child that is wasted but not stunted. And that moderately wasted stunted child has got a similar mortality risk to a child with severe stunting, with severe wasting, but no stunting. So those two on top of each other is a particularly dangerous situation. So what's happening in South Africa? I've just summarized about 10 years worth of national surveys here. There was another one done in 22, but we're still waiting for the final results. But as we can see, the prevalence of stunting is high and has been high for a very long time. The prevalence of wasting has come down a bit, so that's something to be excited about. What you don't see on this slide is at the same time, the prevalence of overweight and obesity has been increasing, but that's not today's issue. So if you were to walk into a school classroom of 30 children that represented the national population, you would find 8 stunted and 1 wasted child in that classroom. And I am giving away my age by thinking that classrooms still have only 30 children in them. So if you think of your average school, how many nutritionally not even at risk, already malnourished children will you find? Why? South Africa is an upper middle income country. Why do our stunting rates look like a lower income country? And this picture, I'm not going to talk you through. I know you've all seen it. But this is just to emphasize that malnutrition is actually a really complex thing. There's a lot of underlying basic things happening. and a lot of moving parts that interconnect to create malnutrition. As health services, we don't necessarily have a finger in those pies, right? But we are on that framework. And I'm so glad Ameena said that our individual contribution counts, because even if you can't fix everything, we can fix some things, right? So where we are right now on the ground, what can we do? The first thing we need to do is we need to find those children that are at risk. Only if we have identified them can we actually help them. So that implies screening for nutritional risk. And once you've screened, you will find some children are low risk. Great. They just carry on with their standard well child services, which does in fact include a lot of nutritional intervention. There's growth monitoring, micronutrients, breastfeeding promotion, you name it, right? But then those that are at risk of malnutrition, those are the ones that we need to keep a closer eye on. We need to offer extra support. And we're going to get to what that is going to be. So step one is identifying the at-risk child. And we love to talk about red flags, right? But in my opinion, the red flag, you've already left it too late. We should be spotting the orange flags and the yellow flags before they become red. And this slide is going to give you a bomb drop of information that I'm not even going to talk through. But what are some of the things we need to look out for? Birth factors, we just had a very good presentation on that, right? We need to look at maternal factors. We need to look at health status. Diarrhea is such a big thing when contributing to SAM. We need to look at dietary factors. Okay, what is this child actually eating? And how would the breastfeeding go, etc. We need to look at household factors. These are the ones that are really challenging to address, and this is where your colleagues in social work need to come in. So it's not just medical professionals, it's social workers. And then there's a few that are specifically associated with stunting. Most of the rest of these are also contributing to SAM. But for stunting, very interesting, maternal HIV, even if your child is uninfected. Placental insufficiency, even if that child had a normal birth weight, and then being short at birth. Big risk factors for stunting. Okay, and then just a note on this, because this is my research thing and something that I am very passionate about, is growth starts when sperm meets egg. So if we only start thinking about growth when that baby is born, we're missing out on 9 months, because fetal growth lays the foundation for everything that comes after. And placental function lays the foundation for fetal growth, because that's nutrition, right? Why do I mention this? Because we can measure placental function. It's no longer something up in the air. And if anyone wants to talk about that, I would love to. And I know Prof. Ute would also love to. Placental function, if we have placental insufficiency, that's associated with lower length growth. And this is research that we've done at Pretoria with lower fat-free mass, which contributes to stunting and, interestingly, to overweight, and with impaired cognitive development. All really serious problems, right? So let's get practical. And when I was contributing this, I was thinking, I'm going to make a nice checklist. And then I started looking at the documentation and I realized it's all there. All the guidelines are there. They tell us what to assess, when to assess it, how to assess it, what to do. So why do we still have so much severe acute malnutrition coming into our hospitals? Well, some things are outside our control, right? You get complex home situations where there's severe socioeconomic deprivation, there's social problems. There are situations where caregivers simply don't come to the clinic until the child is severely, severely ill. There's a limit to what we can do there. But then sometimes we need to look in the mirror, because children do present at primary health care with early malnutrition. I'm going to prove this to you now. And they're not picked up, they're not managed. And there's lots of reasons for this, right? There's not equipment, there's not time, there's not staff. The staff that we have don't have the training, don't have the skills, don't have the knowledge. But I want us to be honest and ask ourselves, when do the reasons become excuses? And I want to show you a few growth charts from my master's project, right? These are all children that were admitted with SAM. So over here, we first see the evidence of a problem when this kiddo is 6 months old. Then just kept coming back. No one did anything. This child was not gaining weight over 3 months of visits. And only when we hit that black line did they send him to hospital. And there's more of the same. There's 5 months of ongoing weight loss, no intervention. 8 months of growth faltering, no intervention. This child had SAM 3 times. So if you, someone's phone is ringing. It's not mine, I promise. That child should not have developed SAM 3 times. We could have done better, is my argument. Here's another case that's a fun one where it wasn't plotted correctly. So it looked like this child recovered really nicely, but when you plotted correctly, not so much. And not surprising, ended up with SAM. Okay, so what can we do? 2 more slides, then we're done. Today we have to work with what we have, okay? And the biggest thing we can do, in my opinion, is to make the most of our routine wild child immunization visits, doing growth monitoring properly, okay? Prems and low birth weights are a challenge. Remember, we must look at length and MUAC too, okay? MUAC is easy to do. We have the equipment. We just need to do it. Length is a bit more challenging, but it can be done. We need to ask moms about feeding, diet, illness, what's going on at home, and give the right interventions. And remember deworming. Deworming and anemia go hand in hand, right? And if you just do what's in the Road to Health booklet and in IMCI, all of these bases are covered. So I'm not saying anything that no one has heard before. What's also really important with those prems and low birth weights is preventing them. And that we're going to do by antenatal care, right? Bank Plus, very good protocol. It's got everything that you need. And we need to screen our moms for malnutrition. We need to monitor their weight gain and their symphysis fundal height, because that's when we pick up growth restriction, first line. In the future, we need to start planning to do better. And I'm so glad Lesley mentioned the electronic health records, because that is a massive opportunity. If we could have a digitized cloud-based Road to Health booklet, that could improve patient tracking, we could communicate among ourselves, and it could automate the plotting and the assessment of growth patterns. This was my master's research, so I know it can be done. We need to make better use of our community health workers and our WABOTs to find those kids that don't come to the clinics. We need to improve antenatal care. And one of the things that is hopefully in the pipeline is implementing antenatal Doppler, which is the test for placental insufficiency. And then implementing multiple micronutrient supplementation rather than just iron folic acid, because there is a ton of evidence showing that that improves outcomes. And then finally, we need more nutrition professionals at primary health care, because counseling takes time, it takes skill. And if you've got 2 nurses who need to see 50 moms on a morning, that's just not going to happen. And with that, I'm going to wrap up and pass the mic to the next speaker.
Thank you very much, Sanya. That was fantastic. We are moving on to Sadhna Bolton, who's Assistant Director for Speech Therapy and Audiology at Chris Hani Baragwanath Academic Hospital. And we're going to think around children with special needs in our little jog around the different risk groups. Yes, so Sadhna, thank you. We are seeing your slides very nicely. And please, we are not going to have so much time for questions at the end. So please, can everybody pose their questions to the presenters so long in the Q&A, and the presenters can go and look there and start answering, please. Thank you. Over to you, Sadhna.
Can you hear me?
Yes, thank you. We
Yeah.
can hear you now.
My disclaimer is that I was asked to do this presentation 2 days ago, so I'm stepping in for Ms. Mukele, who is the Director of Therapeutic Services. So I've put together this presentation as best as I could to serve the need. So when we're looking at children with special needs, sorry, my slides. We know that worldwide developmental delays are increasing, with poverty and exposure to environmental risk being one of the main contributors as well. However, for children with special needs, it's critical that we ensure timely interventions, prevent complications, and support optimal growth and development. Early identification and initiation of treatment is important, but we know in South Africa, under-identification of children with disabilities is of real concern. Risk stratification would allow us to categorize children based on their level of health, developmental needs, social needs, and to prioritize care and allocate resources effectively. One of the models presented has been developed by Boralnik in 2001, where he gives us a model to talk about when a child starts off in terms of screening, how do we develop an algorithm that ensures that they move through the process until they get intervention. And very importantly, something that we are not really good at is transitioning into the next level of care. So this is a model that we have used to train therapists working in the field of early childhood intervention in Gauteng Department of Health through our ECI work group. When looking at this, we try and develop a model where we can look at what is our strategy for children who have different levels of needs. So when we look at a model for all children, this is interventions that children have access to already, and that is, for example, immunization. And this is where we can see that the Road to Health booklet has been underutilized, especially looking at the developmental screening aspect of this. So we have trained therapists to ensure that they look at the Road to Health booklet, but they also train other healthcare workers to ensure that the developmental care aspect of this is looked at. Looking at targeted interventions for vulnerable children, that is children born with low birth weight or prematurity, and then children who require more specialist services, example, cerebral palsy or autism. So what can we do? Provide routine health and developmental monitoring, educate caregivers for promoting optimal development. And I think this is very much what previous speakers have said already, and monitor for emerging needs and conditions. When we look at children that we identify as vulnerable, we need to offer targeted interventions such as speech therapy, occupational therapy, focus on developmental surveillance, and address the social determinants of health, and involving other professionals such as social work and psychologists as well. For children who require specialist services, establishing services at various levels of care that meet these needs. So coordinating complex care involving multiple specialists, and I'll show you a model that the Gauteng Department of Health is trying to introduce. However, it's still in its very initial stages, but I think this is a way for us to move forward. This is one of the tools that we have developed as our Gauteng Early Childhood Intervention Group. These are pamphlets that we encourage people to hand out at well baby clinics, neonatal follow-up clinics, our HIE clinics, and it goes right up from 0 to 3 months to 6 years. And this allows parents to do their own screening as well and get some ideas on how to help the child at home. And this is meant to supplement the information that's already in the Road to Health booklet as well. When we prioritize care coordination for children with additional needs, it requires that there be continuity of care of your primary healthcare professional. And unfortunately, from a rehab perspective, we predominantly have community service therapists in these positions who change year after year and often take the first few months to just learn about the system, learn the community, and learn the tools that should be used. So we definitely are failing there. Collaborative planning that requires an intersectoral approach as well as an interdisciplinary approach to the various professionals that are involved in management of children. Identifying case managers and ensuring that families have a particular person to contact and not having to deal with 10 different professionals, but there is one key person that they can communicate with. Having a single point of access, and this is what the Gauteng Department of Health is working with at the moment. Having clear care pathways, so if a child ends up at any level of care, we have a clear understanding of how to refer up, how to refer down, and what does this entail as well. Building workforce capability is important because most speech therapists, occupational therapists, and physiotherapists who come out of their undergraduate training tell us that they do not know how to work with families. And this is a big concern and something that we have tried through our workshops to improve their level of skill. We've spoken about the digitization of patient records, and in Gauteng, there's the Geneva project, which seems to be at its final stages of input and hopefully will be launched soon. So this is the model that the Gauteng Department of Health has looked at. So creating multidisciplinary teams at various community-based centers and clinics, and then looking at how do you coordinate care. And this was initially started predominantly due to the litigation cases against the Department of Health, but it's now become a model of preference for children, not only with cerebral palsy, but with other neurodevelopmental issues as well. So within these teams, they are trying to look at how do you create a comprehensive service where it's a one-stop shop for families. So not, and I'm sure many of you have seen these files. I definitely have seen them at Barrow, where you pick up a child's file and there are 10 different appointments that they have to go to in 1 month. So financially, we are draining family resources as well. And if we could create a model where there is a one-stop shop for families, it would definitely help. And it would also help families getting the same message from healthcare providers as well. So some of the capacity building that has been done is there's been on-site training for a medical officer within the West Rand region to start these services going there. 120 therapists have been trained on basic CP management. 39 community healthcare workers have completed the short course on CP. And district task teams that includes clinicians and therapists have attended workshops on creating a central database. We've had workshops for dental practitioners, case managers, and this one has not happened yet, but is on the table to train the Pretoria State Attorney as well. We've conducted training for therapists on the Road to Health booklet through the Mother and Child Directorate. We are now also orientating parents towards, so before discharge, going through the Road to Health booklet in our developmental care talks, and ensuring that mothers ask whoever the healthcare provider is that's seeing the child to not only focus on the medical aspect and the growth aspect, but the developmental aspect as well. We've given talks to other healthcare workers about the early identification of developmental delays and disabilities. We currently have a project with the Lego Foundation, with the Chai Foundation, which has funded through Lego, where we have money now for hearing screeners at Christine Baragwanath Hospital and Latham Hospital. And for Barra, through some of our work with learnership programs, we've moved from screening 4% of babies to currently we are now reaching 54% of babies who are getting the hearing screen before discharge. We have therapists running promotion campaigns at well baby clinics and high-risk and clinics for high-risk babies. A workshop for senior clinicians to ensure that when clinicians are wanting to start and initiate services, that they are supported by management. And at Baragwanath Hospital, we've just launched a flagship project for rolling out neurodevelopmental care next year. And this team consists of speech, OT, physio, dietetics, nursing, and neonatology. And we will be trained on neurodevelopmental care and then conducting training for other healthcare workers within our hospital. And this will then hopefully roll out into the province as well. So I tried very much to not get the background music. So thank you so much.
Thank you very much, Sadna, and also for standing in for Mrs. Mukeli, very much appreciated. And for a fantastic talk. I think a lot of it is around organizing services in a family-based approach, and really thinking around how we can provide services to at-risk children in terms of neurodevelopmental delay, and thinking around screening, thinking about provision of services. So thank you very much. That was very inspiring. I wanted to ask, so unfortunately we have run out of time, so we will not be able to field more questions. But so in the chat there were questions around whether the child support grant should is actually going to be extended into the antenatal period. This has been something the health department has been thinking around, whether that would actually improve the access to antenatal care and the food and extra food and transport costs for mothers during pregnancy. So this is something that has been discussed even at cabinet level, I've been told. So we will need to watch that space. Sadhna, then there's a question about asking for access to the community-based CP training. So yeah, so I see you're busy typing an answer there. And then there was a question as well around actually whether we should be thinking around our well child visits, whether we should actually, because we actually have quite a high number of well child visits, more than what the WHO minimum package is, and whether we shouldn't be thinking around actually maybe reducing or streamlining the visits for the babies that are low risk, and actually then provide the higher frequency of visits to the children that we identify as high risk in our setting. So obviously for that we would need to agree on what high risk is and how we and the evidence in terms of this, which is something that Lesley started off with in her package, in her first presentation. So thank you very much for the speakers. I found this a very fascinating session. I really think there's lots for us to think around. This is not a topic that has final answers yet, but it certainly got us going in terms of thinking around this. So that concludes our first session for the morning. Our next session will be at 2 o'clock. I will be handing over to Haroon Saluji. So he will be starting off at 2 o'clock. The session then will be about balancing cost and quality in pediatric care, the challenges and opportunities. So again, thinking around costs and quality of care. How do we best do this? And you would have noted from the conference theme and how we set this up is we are all obviously aware of the difficult environment that we are working in. And the idea is for us to have some hope and hear from what other people are doing and say, okay, hang on, that I can do in my setting as well, so that we really get our enthusiasm back to be change agents in our own local settings. So thank you for joining in. We had way more than 100 people the whole morning, 125 actually, so that's fantastic. And we will see you back at 2 o'clock. Thank you, everybody.